Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flaw podcast.
The following podcast is not relating to my teachings and work at Delcine Medical Center and is for entertainment purposes only.
Willkommen beim Life of Flaw Podcast. Heute begrüßen wir Dr. Michael Lichtenberg. Ist so schön, dass ihr da seid. Life of Flaw Podcast for all of you out there. This was my absolute ode to our German professor, Michael Lichtenberg, a good friend, a fun guy with some incredibly interesting stories about his time in Tulane, Mardi Gras, Houston Medical Center, and all the way up to the tip of the spear when it comes to vascular innovation. Stick around. This was a super fun show. His acumen, come on, nobody needs to know. He's just the chief of the most amazing program ever, period. Done. Full story. Let's go. Well, everybody, we are incredibly happy to have today Michael Lichtenberg. And
that's pretty good.
Thank you. I practiced it ahead of time. Maybe my past life in Deutschland helped me a little bit. So, but anyway, Michael, it's a super treat for us to have you here. You have rocked the world of vascular therapy, I would say, in so many ways. I bet you the intro we could ever make at the top of the show won't be enough. As you have been really involved in so many things. Your name is in so many papers and so many devices that you, I think, deserve no introduction, as people probably already know you. But one thing that we love doing here at Life of Flaw is learning a little bit more of what inspired you and what things in life maybe moved your the wind behind your wings to ultimately become this incredibly important person for all of us. And so if you don't mind, maybe let's just start the show there. Is for those people that have lived under a rock and don't know who Dr. Lichtenberg is, let's give him a little idea of where this whole thing started, and go as far back as you want. Whether it's medical school, before that, just what was your path growing up?
Yeah, so first of all, thank you very much both guys for having me and inviting me here to your great show. I love your podcast, really. I saw a lot of these interviews. This was fantastic. This is great. So thank you very much for having me.
Thank you.
Yeah,
Thank
what
you.
about me? So first of all, I think what you should know is that I'm an angiologist. You don't know what that is, probably. This is something which is common in Europe. So what is an angiologist? Angiologist is dealing with all vascular topics and is specialized, if this guy wants, in endovascular therapy. So actually everything started for me already in the 90s when I was at the medical school. One of my big supporters said just, hey, do you want to come in my labs and see some procedures? Maybe that's something for you. And he invited me to come. I was around 22. So the first day I was in, they found me on the floor because I couldn't see any blood. So I had to train a little bit.
Really? You passed out?
Oh, that's funny.
I passed totally out. Yeah. So that was cool. And I said, okay, maybe I go to a conservative topic, but no. Then this guy came back, said, hey, try it a second time. And the second time it worked. I passed out another time when I first saw an amputation, but okay. Okay, Peter, keep it silent. Don't tell my students or so, please.
No. We won't tell anybody.
Yeah, and,
exactly.
I have a
They'll
question
stay
for
with
you.
us,
Have
yeah.
you ever passed out?
Never.
Really?
I was doing this case once in residency assisting one of the thoracic surgeons. And I think we were doing something like a laparoscopy or something. And the medical student was passing out. And this is like a female attending. She saw the medical student passing out into the field and just like elbowed her in the face to like take her, like have her not fall into the field. The poor kid just
Did she
crashed.
knock her out?
Well, she was passing out,
I
and
understand.
then she like
So did she ultimately?
what?
So she passed out and got knocked out.
No.
Jesus.
Jesus
No.
Christ.
So you know what happened to me? My
Yeah.
story is like so funny because I was a medical student and it was my first surgical rotation, and they put me with this ENT guy, right? Ears, nose, and throat.
Yeah.
And he apparently afterwards I heard he did this to all the medical students. It was this kind of internal joke. And so you know that when they're doing a nose job, they have to fracture the bone in order to, anyway, I don't know about that. But anyway, there was a big chisel, right, through the nose into the bone. And so he gives me the hammer and he says, I need you to like hammer and break this bone. And so, of course, I'm like, this is my first surgical experience, right? I look like a T-Rex because I don't want to like contaminate everything.
Yeah.
And so I grab this little hammer and I like go like pew pew pew, and the guy looks at me. He's like harder, and so I go like knock knock knock, and the guy looks at me. He's like harder, and so I whack it, and the guy was like, "No!" It went into the That's the last thing I remember, and I fell on the ground. And I woke up like an hour later, and they had to pick me and carry me out.
Was this
But
in Costa Rica?
I remember at the time, just the whole thing, and like I had done nothing. Like I just like broke through the bone, and it was what he needed me.
Yeah.
But he screamed like, "No, that's too hard, right? You went through the brick." And done. And anyway,
Oh my
I'm
God.
sorry,
You do that now,
Mikhail, but that's a funny entrance to the story.
if you do that now, you go to jail.
Yeah, it's so boring
You
now.
go to jail.
You can't do anything nowadays. It's not fun. But anyway,
Oh my
let's
God.
go back. So you gave it a second shot. You didn't pass out, thankfully. And then what happened?
Yeah, actually, and then this guy, yeah, he gave me a doctor thesis, and I started to work on a topic about restenosis, and yeah, that was the start of that career. Yeah, I was always wanted, to be in this field. Yeah,
This was
so I
in
never
what
wanted
city?
to be something else. Yeah.
What
So
city were
thanks.
you
Hmm?
living in at
Sorry?
that time? What city and what part of Germany were you living when this first opportunity came?
So this started all in Düsseldorf, which is
Okay.
the west part of Germany, close to Cologne, close to Dortmund. You may
Mhm.
know the
Yep.
famous Borussia Dortmund soccer club. Yeah,
Yeah.
so it's not far away. So I really started there, and when I was a student, and then actually I did 1.5 years at Tulane University, and also at
Mm.
Texas Heart Institute.
Oh,
And
really?
and
You know,
that was the best time of my life, I can tell you. It
When
was
was
so good. We
when
had
was
so
that?
much fun there. Huh?
well, I'll
Hmm?
tell you this. We are recording today
Mhm.
because we were attending the NCVH meeting.
Yes.
So we are about 10 minutes away from the campus. I bet you lived close by to wherever it is that we're recording
Recording, yeah.
today. Because we are in
Ah.
one of these old houses from, close to the French Quarter.
Yeah, I lived in the French Quarter with some other students. That was super. Yeah. It was not the
Yeah.
best time for my liver, I would say,
Yeah,
but it
I
was.
bet you didn't get in any trouble at all.
Were you ever here for Mardi Gras?
Yeah.
Yeah.
The first week when I arrived, Mardi Gras started off. Yeah, and then me as a very shy guy, going to Mardi Gras with some students, and everyone said, "Show me your tits." What, please? What?
Welcome to America.
Yeah. So
Did you end up getting beads? Yes or no?
Yeah.
maybe for the second interview, I'll tell you.
Yeah, for those, if you know, you know, is one of those moments. If you
Oh,
know,
absolutely. Absolutely. Absolutely.
And then you went to, and then, so what did you do while you were at Tulane?
So actually, it was a kind of exchange program with my university. So I stayed there for half a year, working on my doctoral thesis, and then I met a guy from Texas Heart Institute, and he said, "Hey, do you want to also come to Houston, Texas?" I said, "Yeah, that was such a cool time here in Tulane. Why not? Why not going to Houston, Texas as well?" Yeah, and then I went another year to Texas Heart, and again, it was the best best time of my life. And I did not any to do with my studies and so on, but it was a really cool time. And these are the times I think we all remember. I had a little bit longer hair by that time. Yeah, and
You were doing research. You weren't doing any clinical stuff at that time?
yeah, we did with my working group in Germany. We worked on restenosis ideas, theories. Yeah, this came from the cardiologist actually, but we transformed this to the peripherals and started to work on restenosis ideas for the peripherals. So smooth muscle cell proliferation was actually my topic, and what factors, are responsible for smooth muscle cell proliferation. Actually, my thesis took a little bit longer, as you could imagine, because of this very cool time. But
Because of Mardi
A
Gras.
little bit of distraction.
Yeah.
oh,
The rodeo.
Let's call it the language barrier.
Yeah,
Okay?
exactly.
Enough.
Yeah.
yeah, I get you.
Yeah. Did you do you remember? Did you work with any of the more clinical cardiologists? Texas Heart. Do you remember?
Oh
any?
yeah, I actually met the most famous guys still alive there, Denton Cooley. I met him twice. Yeah, I had the honor to saw him operating. So this
Oh,
was
you caught
absolute.
Cooley operating.
Yeah,
Ah,
Mm.
that's cool.
I think it was in the mid of 80s already. Yeah, something like that.
Yeah.
Very
So
old, very old.
when I came to Houston, that was 2016. And I remember one of the most impressive things for me. Yeah, of course, I walked in, just the medical centers, just so daunting and just big, and science and history and museums and all this. But what really impressed me was I heard the elevator open, and then all these people started coming out. All these people were coming out. All these people, and then behind them, Cooley in a wheelchair, rounding.
No way.
Dude,
Really?
rounding. Yeah, very, very obviously, very old and very weak, but he was doing some special rounds that what's happening that day, and so he was in the ICU, and it was like this huge thing, and everybody was there, and then he said kind of a couple of words and gave his opinion on a case,
Yeah.
and I'm like, man, that was cool that I was able to live that with such a legend. But how cool that you were able to see him. So that means you actually went to the old ORs that you could see down, right?
Yes.
Were you able?
Right.
Oh, you
right.
were there?
Yeah. I was there. Yeah.
That's
A
never-
lot of
I
times,
CDOR. You never went
I
there?
never went there.
Oh, those are I don't they don't use them anymore.
Yeah.
But they're still there where you can see that. That's cool that you had a chance to see that. What an amazing time.
this was really impressive.
What do you think that did to you? From a professional standpoint. The Michael before and after the American journey, did it change something particularly, or nothing that you can note was significantly changed in what you wanted to do?
No, you're absolutely right. I think there's a honest question, and it changed me. These 2 years of being abroad somewhere else, trying to get everything organized. I think that was actually the change from becoming a student to someone who is really interested in the field and really want to give the best of it. So I learned so much, and I met so many good friends. Still have contacts with many of them from that time. So this influenced me a lot, and gave me the power then to say, yes, I want to be in this part of medicine. I want to be a vascular specialist, and I think this is kind of birth of this idea there. I was a little bit a party boy before, but this really gave me some input, and made me look forward to start this career. Yeah.
Was it clear then that you wanted to be an angiologist, or at the time you were thinking more of cardiology?
Yeah, that's a good question. In our system in Germany in particular, everything starts with internal medicine education. This is what is done first. Then you decide to do to specify one of the subtopics. Then typically most of vascular doctors go to cardiology, do a cardiology training, and then subspecialized in angiology. So that was also the same for me. So I did a lot of coronary interventions for a couple of years, but then I said, yeah, cardiology, only 3 vessels. Yeah, this is a little bit boring. Sorry for all the cardiologists. I'm a cardiologist, so I can say it there. So I said, yeah, I have to do something else. And then went into the vascular field since when I started in 2006. So actually in this field now for 20 years. Yeah.
And so when you fly back, do you relocate or you stay in the same city in Germany for a while before you change?
Now when I came back, I think I met the best of my life. This was my wife.
Uh-huh.
Meeting her during the end of my university time. We then met, and actually we got then married. Actually, so this was the best. And then we stayed somewhere there in this area around Düsseldorf, and she's a pediatrician, so she did her career in the pediatric intensive care unit, and
Ooh.
myself was in the cardiology, and yeah, it was good.
Did you at any point in time consider pediatrics in your own path?
I think I'm not able to do this. Yeah, when I see what my wife is doing, and she's especially working with disabled kids, yeah, kids who need a second chance. I'm not able to do this actually. So I think it's for me the best to work on the other side of the spectrum. So I think you need to be dedicated for that. You need to be born to really stand these issues with kids who are in a very bad way treated, and she specialized in this field. And when I hear sometimes these absolutely catastrophic stories, kids who get raped, who gets hit for any reasons or something, this is really, really, yeah,
You have to
dramatic,
be
and
an
this nothing
incredible
for me.
human being with deep empathy and deep maturity to be able to provide care for those who most need it. It's a hard thing. When you I I could never do it. The funny thing is I at some point thought I would do it. If you ask me what happened when I graduated from medical school, my plan, I was in love. So I remember my favorite, I knew I was going to be in cardiovascular something. I fell in love with physiology. I ate up physiology. It was just so logical. Hydraulics, pressure up, pressure down, open, flow goes here, there. Beautiful. The heart is so easy to once you get it, it all makes so much sense. And on top of that, there was a pediatric interventional cardiologist. Last name was Mas, M-A-S, and he was amazing. And I remember him fixing some kids, and I thought that's what I was gonna do. And so the way that they would do it was smart because what they would do is they would give us jobs in the emergency department. hmm In the emergency department, and so I was like a general practitioner in the ED of the kids hospital. And so you would see all these really terrible things, right? Because it was a trauma one center too. And the pain and the suffering that I would see in these kids and in their parents was something that was just unbearable. And I remember, one day just coming out of a call where it was horrible. And I believe there was a social issue like you were alluding to before. And I said, I just can't do this. And my whole career, I thought that I was like dead on. I'm going to be a cardiologist and I would be a pediatric interventional cardiologist. And I just couldn't. And to your point, I went to the absolute other spectrum. I thought, what's the absolute opposite of this? Is the geriatric population, which still needs a lot, right? I mean, there's a lot, and there's also social issues and all these other things, but it was just, and so then I was like, okay, well, I'm going to go and you'll become a vascular surgeon. And I changed completely my tune after that. But it's great to know that there are people that can still help them. Yeah, can still help them. So at what point in time in this story is there a relocation? You do coronaries for a while, then you decide to do your vascular stuff. And then at what point is there a change in city or program, or how do you end up to where you're at now?
Yeah, so when I finished my cardiology training and then I was looking for an angiology training, I went to Essen University and to some hospitals in Essen. There I started my angiology training and especially endovascular training. And then suddenly in 2012, someone called me. His name is Dr. Stalov, one of my best friends. He was one of the first in Germany doing endovascular procedures. So there were only a handful of people who started it by the end of 80s with endovascular procedures, beginning of the 90s, and he was one of the first. And he said, "Hey, do you want to come to Arnsberg? Because I'm retiring in a couple of years, and let's work together and build here something up." So by that time, he had a one-man show in the city where I'm now practicing, doing 500, 600 interventions on his
Oh my
own.
God.
I was really impressed when I saw this, and he said, "Hey, the management will give us a second lab. I need a second interventionalist, and do you want to stay here and work with me?" And everything started then from 2012 in Arnsberg, actually, in the department, and yeah, from that on, it really exploded. More and more physicians came. We are now a group of 12 physicians.
Wow.
We are 7 interventionalists, having 3 labs, and everything started. We opened a study center there during the time, and yeah, when my colleague retired already in 2019, he's now 74. Said, yeah, we need some more people, and then yeah, really a specialized angiologist came and yeah, started to build up more and more this center in Arnsberg. And actually, this is a great team we have in Arnsberg now with these 12 physicians, 7 interventionalists, so many study nurses, and wound care specialists. Yeah, that's actually a dream I ever dreamt in the past. Yeah, having such a great team working together with specialists in the different fields, and yeah, that's where I am now.
And
Yeah.
what type of model is this? Is private? Is here in the U.S. I guess. I don't know how the models in Germany.
Yeah, so we have different yeah, hospitals in Germany. We have university clinics, of course. We have teaching hospitals, and we have private hospitals. My clinic is a teaching hospital, which belongs to the University Clinic of Münster. So we see a lot of students. So educating is some of the real hobbies I have. Yeah, training the new generations. And I think that's super, super important. And I think that's the future. And so they have the right to be educated well. And so we see a lot of students. So we are a teaching hospital, meaning we can do a lot of research as we are associated to the university clinic. And that's what we're doing. I think at the moment we are doing around 30 studies with the study department of our unit, yeah. And then in 2015, something happened. The vascular surgeon by that time, he also retired and said, we need a new vascular surgeon. And then I met the vascular surgeon. His name is Bernd Geringhoff. He came from Professor Torsello in Münster. I think everyone knows Professor Torsello. And yeah, from that time on, yeah, we really had one department. Yeah, we said, yeah, we have to do this together as one team, working endovascular specialists with vascular surgeons, doing all the stuff together, doing the high risk things. And this is actually something I learned to do this with someone who's so specialized in vascular surgery. He saved my ass actually so many times when I failed or did any complications. So it's now in the 11, 12 years of cooperation. Yeah, and I think that's absolutely super important to have an interdisciplinary team of the different specialities. And together with Bernd, I have to say, yeah, we can definitely rock it because everyone has his specialty. I do the endovascular works. If I fail, then he can take over, do the bypass or whatever. And yeah, that's great.
And I love hearing stories of successful multidisciplinary models that have endured the test of time. And you guys have certainly been a place that should be probably studied conceptually. Like, what are the blueprints to be able to integrate all these cardiovascular services under a flag and make it work? But even more interesting, or as interesting, is how you've really become a mecca for research. I mean, to hold over 30, and I'm guessing you're saying 30 active, but probably since you've been there, it's probably going to be hundreds of studies that you've been able to open, enroll, and close and move on to the next ones. And that's something that I would love to understand. When you look back at how you've become this, um, even in the era, in a way, I feel, like I remember that. I'll set the stage of this question in a little bit different way, which is when I was with Dirk and Andre, it was 2006 to 2000 and take 7, 8, about 3 years in those times. Everything in a way was happening in Europe. The FDA was so hard to work with that most companies had moved in a way and were seeking places to start doing a lot of this. Whereas I feel that in this 20 years has changed some, where there's disincentives from the regulatory aspect in the European community, yet you guys have emerged as I said Mecca, as a powerhouse in research and continue to be incredibly involved with this despite some of the regulatory hassle. So if you don't mind, can we talk about what do you think has made you guys so successful and have so much solid good data to shape the way we care for our patients in the last 10 years?
Yeah, it's always being there in the perfect moment and meet the right person. And it was the same for us in Germany, I would say. Yeah. Um, as you mentioned, by that time, 10 years ago, we had a more liberal situation for studies for new devices to bring it to the market to evaluate these devices for endovascular therapies. And so the momentum was great. And I met a person actually in 2013. Her name is Simone Müller. So Simone, if you can hear me, I really would like to thank you because she's our lead study nurse. And she said, hey, I'm a study nurse and let's do something together. Yeah. And she's so enthusiastic and she's so innovative, and she's from that time on, everything exploded. Yeah, more and more studies came. We are now a team of 8 study coordinators. Yeah, and it's so much fun with working with them, and so effective. So they all make a great job. So kudos to my team, to my study team, absolutely. Yeah. Unfortunately, and this is what you mentioned, then we had to shift to a medical device regulation a couple of years ago. And this is unfortunately now changing a little bit. It's getting more and more complex to organize these studies, to bring new devices on the market. I think the way you do it now in the United States is something we definitely need, with the fast track, with the breakthrough ideas. We don't have that. And so we are losing a lot of ground now, especially in evaluating new therapies. And this is really sad to see. Really sad to see.
So you've seen so many different, you know, devices, so many different trials. What areas do you think are overdone? It's like we don't need any more of this. And what areas are we like not looking not looking enough into, or what areas do you think we like in the future this is the next big thing in your opinion?
Oh yeah, that's a good one. There's the 1 billion of open questions in the peripheral field, including venous disease. Yeah, what we probably do not need is another stent. Stent is something.
That's what I said. You said atherectomy. I said venous stent. We don't need another one.
We had a
Yeah,
bet
yeah,
going in the background.
yeah.
He's like, what do you think he's going to answer if we ask him, what do we need not more of? And what do we need more of? And I said, he's probably going to say not more atherectomy devices. But
Yeah.
you said venous stents.
Yeah, right. So, but I agree. Also, atherectomy devices. There's every week a new startup company bringing a new device on the market. I don't know. It's getting a little bit crowded here. So yeah, so I think yeah, that's that's something. It's okay. It's good to have some new ideas. There's some nuances improving, but there's so many open questions. Why do we still need to amputate? Yeah, why there are still no option patients? Yeah, so how can we avoid this? What can we do from an endovascular therapy and in these patients who have no options? Yeah, this is the arterial field, but also in the venous field, 1 billion more questions. Patients suffering from post-traumatic syndrome, we can't revascularize because the inflow is so bad. So what can we do to increase the inflow for these patients, preventing rethrombosis or restenosis of the stents? Yeah. So, billion of questions. I think we are still at the beginning of finding answers. So the next generations will probably do this. But it's great to see that there's still so much effort and intense working and studies trying to answer these questions. And this is great to see. And it's great to see actually in Germany that young people are super interested in this field. Yeah, this gives a very good feeling that this medical field of vascular and vascular interventions and the vascular procedures, angiology, is still alive, and it's still under improvement and getting better, bringing new generation at the level that they can take over and actually bring everything forward.
I think that one of the things that and I don't know if it's even possible, if there's even a way to do it, but bringing the arterialization into a more proximal geographical area. So, I think I don't know if we have a good answer besides, vein and a bypass for when a patient has like a distal popliteal disease, tibial trunk disease, proximal osteal disease of the tibials. Because an arterialization there is more difficult, I would say technically. And there's, besides a bypass with a vein, there's no really good answer. And sometimes that's not even a good answer. So, that seems to be a problem that is unsolved. Like when I started in 2018, when I went with the cases that made me nervous, where I didn't know, where I couldn't predict what the outcome would be like acute thrombus. And I think with the myriad of thrombectomy devices, like arterial thrombectomy devices, now I'm like, that's not even an issue. It's like an SFA occlusion. I just think about it the same way. I said, oh, I'm going to fix this. This is easy. The ones that I think are like, how am I going to solve this problem? Are the distal popliteal tibial trunk patients that don't have a good vein. It's like, okay, how am I going to solve this problem in a meaningful way?
I'm not following this. Like a CP trunk occlusion?
Yeah,
That's a cheap shot case. What are you talking about?
I'm saying like an
Process
extensive.
stented done.
Okay,
What are you talking about?
You're gonna stent into a tibial?
Well, yeah, you now have bioobservable scaffolds.
I don't think that the results are that great.
Well, anyway,
Yeah.
so I do believe that when we look into this conundrum of arterial and venous, I feel like in venous we're just starting.
Really?
Yeah, I know. Like these, don't you like? Would you think that the race of technology in arterial and venous is about the same, or do you think that arterial is progressed a little bit more than the venous side overall? Apples to apples, that's our comparison.
Oh, what's the unmet need there?
Well, he just mentioned one that I think is incredibly disabling that causes a lot of patients harm, which is post-thrombotic syndrome, and you can't do a lot, right? Deep venous reflux or venous occlusions of femoral popliteal and tibial veins is incredibly disabling. And these patients come to you for answers, and you know the problem, and you're like, I can't do anything. Like, yeah, you're gonna get wrapped, and that's all we get. Like, right? I don't. What's your thought on that, Michael?
Yeah, fully agree. And just think of the age of venous patients. They're young. Yeah, they're typically younger, significantly younger than the arterial patients. So they have their life ahead, yeah, and we really can't help them in the way we would like to do that, yeah. A 25-year-old female, a mother who's not able to play with the kids in the garden because of venous claudication and persistent swelling, etc., yeah. And we do not have the best treatment for them, yeah. We can
Yeah.
put a stents, and then we see the stents occluding because of bad inflow, yeah. So there's so much to do in this field. And this actually affects me every day when I see these very young patients. We need to find so many solutions here. On the geo field, of course, unfortunately, I have to say, I think it's the same in your country that arterial patients get younger and younger. This is also a dramatic situation, and we see young female patients in the mid-40s having the disaster of aortoiliac occlusions. Yeah.
Mm-hmm.
Yeah, this is something.
Those are difficult cases.
Very
Yeah.
tough. Those young
Yeah, absolutely.
females. Yep.
Yeah.
Yeah.
Yep. So if you had $1 to invest, Micha, would you put it into an arterial company or would you put it into a venous company? If that was the only two options.
Yeah, at the moment we only see two startup fields in the venous field. This is thrombectomy and stenting. Yeah.
Right.
So I think this is not the solution in the venous field. Yeah, you see, we have the 26/7 venous thrombectomy system. Yeah, why do we need it? Yeah, it's not bringing a breakthrough thing. Yeah, and we have in Europe 13 or 14 venous stents approved. Why do I need 13 stents? Yeah. Yeah. So therefore, I would say at the moment, investing in a venous stent company or a venous thrombectomy company, I don't know. But on the arterial field, I think there's so many good things coming up, new ideas. Yeah. And one of my personal campaign is, I put a hat on and write "Stop POBA." So
I love that.
Stop.
Yeah,
POBA?
I love that. Can we talk about that? Because I love all the reactions you got. Anytime people are gonna. Here's the deal. Remember, we said it was success. The first thing we got hate mail from people from what we're doing, right? The moment people said the bearded guy is obnoxious, he speaks too much. I said, great. I have fan hate mail now. And that's when you know something's wrong. So he went online and created this campaign
Yeah.
about stop plain old balloon angioplasty.
Okay.
There is no space for plain old balloon angioplasty in a contemporary vascular care model that has so much data to support better patency rates from all these other things. That why is this POBA first thing still even a conversation on the table?
POBA first. Yeah.
This is pretty much. Would you mind going into why he decided to do a campaign, including merchandise?
Oh, really?
Oh yeah, no, he has a hat. There's a hat
Yeah.
he wears.
Let's plug it.
it's not in red. This hat, yeah.
It should be.
It's a black one. Yeah.
Yeah. Can it be?
Yeah, we'll have to come up with some sort of MAGA thing.
Yeah.
that
How
makes
can it be
them-
MAGA related?
Make balloons go away
Yeah,
again?
Yeah. Exactly.
I don't know, something
Yeah.
like
Right.
this.
Right.
Make
But what?
make paclitaxel great again.
Tell me a little bit about that and why you decided that you had to make a little bit of an open stance on that.
Yeah, because I think we as interventionalists, either vascular surgeons or angiologists, radiologists, I think we have two tasks: make it open. For this, we have, godfathers like Marco Manzi, August Iser, the real guys for that. They make it open. I think this is super important. But the most important thing is keep it open. So these are our two tasks: make it open, but we have to think on keep it open. And I think we can't just rely on painting some drug on the wall and start to pray. It didn't work in the past. We saw so many negative studies from BTK, even drug-eluting stent studies for BTK, which didn't work out. So we have to, I think, come from a different direction and start the story from the beginning on, not that the last chapter. The last chapter is maybe the paclitaxel or sirolimus. But the steps before that are super important. Preventing of recall, preventing of dissection, creating a stable lumen. No one is concentrating on this topic when setting up DCB trials, so they failed. So concentrating on that, achieving a stable lumen without dissection recoil, I think, is our task to then maintain the patency in conjunction with paclitaxel or sirolimus. And I think we need to concentrate on these first steps.
Yeah, when we had Roberto Ferresi here, we talked about a little bit of just talking about tibials, the pathophysiology, and he explained that, approximately we see typical atherosclerosis, but the farther down we go, we see a different pathology in medial artery calcinosis. And so, like, what is vessel prep for that? What is, how do you prevent recoil? What is recoil in a vessel that has a really thin media and is full of smooth muscle cells? I think that's a challenge, and I don't know if we have an answer for that.
No, we don't have, but
Yeah.
we have to concentrate on that and put it in our studies and trying to find answers here.
The problem is that when you pragmatically try to say, okay, well, the intention of our objective as caregivers in the setting of these patients is to provide enough patency to overcome an injury, right? To overcome an infection or a wound. And what happens is that most of the time, some judicious balloon angioplasty may just get you that result, which makes the argument in a way, is patency really matter, a hard one sometimes to defend if you can get somebody through that. But the question is, where I think that I am absolutely in agreement with Michael here, is the sense that this is going to be a problem long term. And you are being incredibly simplistic if you are just thinking that this 3 months at best of patency on a long, complex tibial is going to be the right answer for a patient when they have 30 more years to live.
Yeah.
Right. And so whenever I remember having these very, very vivid discussions against some of our very classic surgeons at Baylor, where they were like, balloon is the only thing, it's never been proven against it. Great, because you're seeing myopically this one injury in this 3 months process, but do your job for 10 years. And there's no way you're going to tell me that you've never had to see the same patient multiple times throughout their life for multiple events. And if you're telling me that if I could have done one thing that would have stayed open forever, that somehow would have been not as good. I mean, am I saying something crazy here? That this, obviously, you put apples to apples on one event, yeah, maybe, but then what happens with the next 20 years of their life?
The problem is the same pro-inflammatory state that caused it is still going on, right? So I feel like if we think that we're going to find some magic bullet that we're going to intervene on that is going to affect the long term without intervening on the bad decisions that human beings make as far as, like, eating, exercise, lifestyle, then that's a losing battle. I just don't think that there's a solution there.
So your thought is we're never going to get an answer.
No, the answer is lifestyle changes.
Understand. We're never going to get an answer to terminal disease. In a way, once they get it, and they're fucked.
I think that you have it at some point. We're gonna have to come up, and you see it with all this, like, it's gonna move from one part of the demographics to another. That these lifestyle changes are gonna have to be hand in hand. You're gonna treat the acute, but we are horrible at treating chronic disease. We're horrible at treating chronic disease.
I agree, but
yeah,
until
so-
you fix,
because we're looking for the
until
wrong.
human beings are gonna be well behaved, you're gonna have to be realistic and know that you're gonna take care of these patients. And I
For
think,
sure, yeah.
I'll bring you back in, Michael. Is the solution is gonna be complex? I think it's gonna be understanding where the plaque is. To your point, Lucas, what type of plaque, where it is in the evolution, what personalized particular care will work there, what will work in a different place, and understand what will keep things open the longest. I don't think it's going to be an easy rubric, and it goes back to, quite frankly, what you decided the very beginning of your career. You said 3 vessels is going to be a heck of a simple process. Well, now you're dealing with 30 or 40 different vessels, which they probably all behave pretty differently. And the solution, I don't think, is going to be easy. What's your thoughts?
Yeah, absolutely. Yeah, I think the term complex really describes it well. And I think we have so many open questions here. Um, and I think it's too simplistic to just say inflate something and then all is good. I think already proven doesn't work. So we need to work on solutions, and I think the complexity is here that, like I just said, not every territory is the same like the other one. So we have to find specific solutions for BTKs. BTKs are different than above the knee, and this is again different to iliacs. So this is the super complexity. But I personally believe the most challenging patients are the CLTI patients. So let's start with BTK. Let's find here better solutions. Stop this POBA thing.
As a mantle, yeah.
Uh,
As an
yeah.
answer for all, a one for
Yeah.
all.
That's, yeah. Kudos to Andreas Grünzig. Yeah. Yeah. Without him, we won't sit
Yeah,
here.
who
Yeah.
50 years ago
Absolutely.
gave us this, but it can't be the same
Yeah.
tool.
Absolutely. Absolutely.
I'll make a comparison to something that I found incredibly funny. I remember many, many years ago being invited to, um, by a group of people. A court is nothing against them, but at the time, it was something like they called me to go to this dinner. They were going to throw all this money into this one dinner, and they're going to invite all these doctors to celebrate. I want to say something like 50 years of the smart stent. And I was like, "Do you realize how actually funny this is that you are celebrating the fact that you have done nothing to innovate?" And it is an ode to the absolute no R&D.
Yeah.
So,
Yeah, it's to say, it's like, to your point, kudos to Andrea. Yeah, thanks for giving us that. But can we move on? Like, can we realize that there's way better options out there? I know if my good friend Dr. Tricia Roy is listening, because I know she's I don't know if a fan, but a follower that sometimes tells me that she's listened to a show. But I think that I think it starts at the beginning, at the categorizing it. And I think, her and the folks at Houston Methodist putting a lot of effort on advanced 7 Tesla MRIs to attempt histopathological um, visualization, with non-invasive manners that would allow us to say, you know what, there's 7 types of plaque, there's 20 types of plaque, and here's where the plaque is. And maybe the solution is something really complicated, where, the proximal 2/3 require atherectomy and balloon angioplasty with drug-coated balloon. There's an area that needs a stent, and then at the end, you need a temporary scaffold that goes into that to keep to personalize care to that one vessel. I don't know, but it could get that really complicated, and I just don't know what the practicality from a social standpoint is it going to be. Is it going to get to a point where it's just absolutely impossible due to the complexity to really find the perfect solution in the rubric of the 5 different tools that one single vessel requires to stay open? But
Somebody,
I mean, it starts there. Maybe just let's categorize to know what we're treating.
I think it's going to be that. I think we're going to provide, the talk about inflow is going to be up to the ostium of the tibials. And then after that, it's going to be some degree of neoangiogenesis,
Like a creation of a new path, totally. A
be
totally
it
new
through
path
like
somehow.
arterialization, venous arterialization, or like that tibial
So you're
cortex
giving
transfer.
up on native, essentially.
100%.
Okay. What do you think, Michael? Do you give up on native? Do you think we're going to figure out how to keep a native vessel open below the knee and the distal third, let's say?
I don't think, no, probably a little bit different here. Not giving up here. Maybe that's the difference between vascular surgery thinking and angiologist thinking. Maybe.
Maybe. I know, I'm with you. I think that we're going to figure it out. I just think the solution is going to be really expensive, and that's what I'm afraid of.
Yeah, that's the point. And maybe here in the future, also modern technologies, gene therapies are also invading this field here a little bit more with new vessel creation or something like that. It could happen. Yeah, 10, 20 years.
Mm.
when we are sitting on an island drinking beer and looking back, maybe.
I sure look forward to that. So let me use the last few minutes we have here with you to talk about what I think is a really cool project you've been involved with here lately. You're putting a lot of energy, at least cognitive energy, with a group of guys into this PO app and the diffusion of digital care. Is that something that you're excited about? What that creates? What that in this current world where everybody looks at their phones for their information? Tell us a little bit about that project if you can share something.
Yeah, absolutely. So PO is an app. It's an app bringing all conferences in one app, so that you're missing the future no conferences, any symposia, etc., etc. So it's all in there. So this is the live part, and the on-demand part. We have now hundreds of recorded cases, interviews, presentations in there. So it's all within one app, connecting the individual vascular specialists actually in one app, trying to bring them together to network. This idea came up already a couple of years ago, and then we started to work around and ask people, can you support that? Can you give us $1 for that? So it took a while, but 2 years ago it became live, this PO app. So kudos to my co-founders, Arne Stachmann and Bastian Görl. They are the real specialists here in technology. I know how to write app. I don't have any more insights in the technology. So, but they made it. And we are now in 146 countries with downloads everywhere, in China, in India, Australia, wherever. And this is actually our goal, connecting the whole family of vascular specialists. And we are working that, bringing more and more features into that app.
What does PO stand for?
So it's a personal education organizer.
Oh,
Yeah,
oh,
you
I
can
like it.
individualize
Yeah.
your search for congresses, symposia, etc. in this app. There is no need to register. So in terms of data protection, no issues. You can just individualize it to yourself and search for that. And then we have direct shortcuts to every congress. So every congress also promotes its own congress on this app, because we directly link to this congress. So you just tap on whatever a WEED congress or Beaver, and then you land on the landing page directly, and get all the information you need. You get event alerts if you want. Yeah, you get informations. You can set up individual what you want. And what we also do is we build Congress apps within this app. So we find a very cheap solution to save money, especially for smaller conferences, to create a conference app, from standard apps for conference where you pay thousands of dollars for such an app. We found a very cheap way to do this within this app, offering to this very cheap technology to every conference, so that it's gonna be affordable for these conferences.
Is it also the intention that, because that's one of the things I remember being a pet peeve that I hated is, if you go to 5 or 6 of these, then there was always an app for each one.
I know you had 1,000 apps on them.
And then each one had a username, which I never knew. And then if there was, then the next year it wouldn't work. And it would just be this pain. So is the intention that by then offering this, the meeting that does that essentially moves away from having their own app and makes the PO environment their place to be? Is that correct? So like I'm talking about from a conference standpoint, that let's say they need to change things. Speaker, Michael got stuck in a plane, won't be here. There's a substitute. Somebody in the office has access to a portal that can update that so that all the attendees have the new agenda. Does that plasticity and capacity to change on the go allow for both sides?
Yeah, so we have backdoor entrances. So when Miguel is stuck on the plane,
Got it. Yeah.
we can immediately change the name. So this is the technology we have available. so you can change whenever you want. We offer this to the Congress organization team, so they get the backdoor key and can update the conference app whenever they want.
Now, do you have to be registered, I'm guessing, as an attendee? Like if I have to pay my dues to go to Link so that I can get into the Link content through PO, I'm guessing, right? PO doesn't just give you free access. You would still have to have access to the meeting in order to access
Yeah,
that.
absolutely. Of course, you have to pay the entrance like for Link. But for Link, we have now a long-term cooperation just signed up. So it's a great cooperation with the Link team. So we organize all this stuff for them, the conference. We are starting to organize their abstracts also now within this app. So these are always new projects within this idea.
Is there any content that is unique to the PO app that's not necessarily tied to a conference? You were mentioning there's a lot of videos and stuff. So if I were to today get a username, which this is an open invite to anybody listening to the pod today, you need to have this app. Go download it, get into it. I'm guessing it's free to get into PO, right? I mean, you don't pay any due.
Absolutely, yeah.
So
You don't pay anything.
is there any organic content of the PO app that you would get access by just having a free account?
Yeah, you get education. You get vascular education because, especially with the on-demand platform, you get so many training videos from all these famous guys who send us their recorded cases, who send us their interviews, etc., etc. This is what we also want to offer. Everyone should have access to a free training and education. This is what we also would like to support. You don't need to pay billions to be educated. Go to the on-demand platform, watch the videos. You learn so much from these great guys who are giving their lectures there.
Here's one last question for you, and then we'll let you go and be in peace. I know it's late in Germany. Thank you for giving us your time on a Friday night, which you probably should be doing something fun.
Yeah,
with
I
your-
went to the
with your
party
beautiful
party
wife.
night.
I
Yeah.
won't tell you.
Yeah.
I won't tell you.
Instead of us. But thank you, and we appreciate it. But I just wanted your thoughts on what you think about this sort of um, efforts like the Life of Flow in the current state of education and dissemination of information. And this I say, knowing that you're biased as a positive supporter with the PO app and some of the efforts you do to disseminate education and the conversation, is what do you think about efforts like the Life of Flow in your mind?
So I'm a fan of your podcast for a long, long time because I think networking is one of the most important things, bringing people together, learn from them. With that, we can actually improve. So these kind of interviews, these kind of discussions are helpful, super helpful for me personally to learn and to improve in my daily routine. You are quite unique with this podcast and actually always good fun. I think the most, the biggest laugh I had in the past was when Marianne Broadman said she wanted to become a nun or something like that. Yeah. So I will never ever forget that. Yes.
Yeah.
That has
Yeah.
been a highlight of ours.
That was so funny.
Very funny.
She seemed like she was a wild girl.
Yeah, she had not only did she not want to be a nun, she went completely opposite and made her hair purple and almost get kicked out of the farm. But anyway, Mikhail, thank you very much for your time, and it's been just amazing. And you're just you're just a cool dude, and we look forward to your ongoing success and growth. And the invitation I always tell all of our guests is if you're anything cool or at any point in time you want to come on and share something with us, just reach out because you always have an open door policy at the Life of Flow. This is your home too. And by the way, let me put him on the spot. He was saying at some point that we should have the show reproduce in PO.
Okay, let's go.
Maybe some of our shows, if you don't want all of them, we can talk about how we make that happen. But I think PO could be a really beautiful home for some of our shows, if not all of them. And people can access it also, the free information and education the same way we put this free for everybody to listen to.
Fantastic.
Michael, thank you
All
very
right.
much for
Thank you.
everything. God
Guys,
bless you.
thank you
and
very
be
much. It
well.
was a pleasure.
Bye.
Take care. Ciao.